All right, we're going to go ahead and get started. Wait, the laser's on. Oh, you switched it to laser. That's good. All right, I'm John Leever. I'm a neuroradiologist at the Kansas University Medical Center. This short talk is going to be on MR diffusion weighted imaging in the brain, how that works, how we can utilize it to appropriately age ischemic infarcts, how T2 shine through works, what that is, and what happens when there's superimposed hemorrhage, which is, of course, common in the acute stroke setting. I have no disclosures. Now, diffusion weighted imaging, like pretty much all MR imaging, is pretty much entirely dependent on protons, how they interact in different fluid and tissue environments within the magnet. But diffusion imaging, what is unique is that it's pretty much entirely dependent on how they move or their diffusion or motion within water. And so what's going to be very helpful is to look at that motion of protons in different intracranial environments. So for those purposes, in these little pictures I have, we're going to imagine that these little gray circles, these are the cells or neurons, and outside of that, we have an extracellular interstitial fluid space. And these little red dots, not my laser pointer, but the other dots, these are the protons. So not to scale, but that doesn't matter for these purposes. In the normal brain, there is diffusion occurring in the extracellular interstitial fluid space. It is not great, as we can see, but it is nevertheless occurring. When you have an acute infarct and the cells die and they have what's called cytotoxic or intracellular edema, and they swell, they restrict the proton diffusion and block off that extracellular interstitial fluid space as such. Very much like the deployment of airbags in a motor vehicle collision, restricting the movement of the passenger. Now, it won't stay like this forever. Eventually, the cells are going to lyse, they're going to break down, and the fluid will leak outside of the cells into what is called extracellular edema or vasogenic type edema. And in that environment, the protons will move even better in most cases than normal brain because it's a high fluid state. The protons move very well, so there's more motion. Time goes on even further. If it's a big infarct, it's going to liquefy entirely, undergo encephalomalacia, or basically be a simple fluid state like CSF. And in that environment, the protons move the best. They're going to be, simple fluid, great movement. Now, how do we take that and look at, what happens in terms of what we actually see on the diffusion weighted imaging? So diffusion weighted imaging, it is T2 based, just like a T2 spin echo, a flare. Diffusion weighted imaging is also similar to like an SWI, a gradient. They're all T2 based. So what we see is T2 signal intensity. So we're seeing that over here. And then down here we have the B value, which it's dependent on. And that is depends on the magnetic field gradient strength and time. And that is very hard to understand. I don't understand it. I don't expect anybody to really understand how that works. But conceptually, what works is just think of it as time, and it works just fine for the purposes of understanding diffusion imaging. So at time point 0, you have your B0 image. Everybody's seen that. When you pull up your DWI images, you have to scroll through that to get to the dark CSF images. And that is essentially, it's a crude T2 gradient sequence, and that's what it looks like. Sometimes scanners will send a third data set where the CSF is iso-intense, and that's called a B500. So think of that as like a midpoint in time or time 500. But what we're looking for and what we want to interpret, if we're doing it correctly, is the B1000. So that's your dark CSF image. And sometimes scanners will label that as a B1000, sometimes a DWI, sometimes a trace. Different names for different vendors, but that is the one we want to interpret. You can ignore the other images more or less as they are source data. And all you need to understand in terms of like how this works, the important concept is that with time on diffusion weighted imaging and proton diffusion, there is signal loss. So if we look at the CSF, as we know, it's going to be the bright because of its high fluid content on the B0 starting point. But because, as we just looked at, it has the greatest diffusivity, it loses all of its signal. And on the B1000, it becomes the darkest thing, much darker than the normal brain. The brain, is going to start off not as bright as the CSF. It's not as high of a fluid state, and it does diffuse and lose signal, but at a lesser rate, so that now they flip-flop. Now it is the brighter thing than the CSF, and where they cross is the B500, and that's why you see what you see on diffusion weighted imaging. So what is the ADC? The apparent diffusion coefficient. That is the slope of the curve. It's just how much diffusion is occurring, how much signal loss. The rookie mistake would be to look at a B1000 or a DWI and see bright signal and say that's diffusion restriction, when in reality, it is the ADC that tells us how much diffusion is occurring. So the CSF is very bright, high diffusivity, the brain is more gray. Also keep in mind that the calvarium is dark on all sequences, so things that are T2 dark will stay dark. There is no gaining of signal. So now let's look what happens with an acute infarct. So we can expect an acute infarct is a high fluid state. So left MCA territory infarct, it's going to be bright on a B0 because it's a T2 sequence. We can expect that. So it's going to start somewhere not as bright as CSF, but brighter than brain. And because it's going to maintain that signal, it's going to be very bright on the DWI. And so if we plot that, this is where diffusion weighted imaging earns its money, why it's so good at detecting acute infarcts, because it stays very bright, and it's now way brighter than brain and CSF and everything else on the image. And of course, the ADC tells us how much restriction or how much diffusion occurred, which is none, and it maintained that bright signal because there's no signal loss. It's going to be black. So now moving on to the more complex concept, and that we see this commonly in the subacute stage of infarcts. So here we have a late subacute MCA territory infarct. Again, on the left, they've had their hemicraniectomy. And as expected in this state, where now we have more vasogenic type edema, gliosis, maybe some early encephalomalacia, it's very bright, as expected. So we're going to expect it to start off somewhere here, very bright. On the B1000, it's still expected to be bright in the subacute stage of infarcts as such, but now we see on the ADC some bright signal. And that's what we expect to evolve first, to have this go from dark to bright while still being bright. And the way that this works, that you can have high diffusivity and still be bright on the B1000, is that if something starts off bright enough, brighter than normal brain, it can lose signal even at a greater rate, but still be brighter than the normal brain on the B1000. And hence the term T2 shine through. If it's bright enough, its T2 signal shines through, it just can lose signal. It is diffusing, and that's why on the ADC it's bright. And that is the concept of T2 shine through. Now looking at these side by side again, this is the acute infarct up here, and this is the subacute infarct. You'll notice it's not as intense, which makes sense. It's going to lose signal. But again, it's going to be bright relative to the dark. So this is what changes, though, entirely first is the ADC. It's going to go from black to bright as it evolves into the subacute stage. For completeness, we have a chronic infarct. Looks like that just on the B0 because it's a T2 image. It's got ex vacuo dilatation, and it's following CSF entirely because it's liquefied. Of course, that's going to lose all of its signal and be black on the DWI, and follow CSF entirely on the ADC, just as expected. Question comes up. Sometimes clinicians want to know, especially if it was a clinically silent infarct, you're detecting it for the first time. What is the age of these infarcts? Maybe it's a lawyer that wants to know. They like to know such things. But the honest answer is it's very inexact. We don't really, can't narrow it down that much. But for the diffusion restricting appearance of bright DWI and black ADC signal, that's going to show up within minutes and last up to, a couple weeks. Subacute infarct, the bright DWI and the T2 shine through appearance, where it has now elevated ADC, that might take a couple weeks and last up to a couple months. Enhancement, which doesn't happen very often in infarcts, but when it does, is somewhere in a 2-day to 2-month range in general. So when I see enhancing diffusion restricting infarcts, I'll still call it an enhancing early subacute appearing infarct, even though it's restricted. And then chronic infarcts where it looks like CSF, that can take around 2 months. But there's big variability amongst these from person to person and stroke to stroke. So because of this big range on the diffusion restricting appearance, I would use that term acute or early subacute when I don't know the timing. Now switching to another important concept that's a little different is hemorrhage. Hemorrhage also, with hemorrhagic inversion or just hemorrhagic strokes, very important in the stroke setting. And the concept of what's hemorrhage going to look like on blood sensitive imaging and diffusion weighted imaging, it's really the same concepts apply to both because they're both T2 based. They both have a gradient and a susceptibility effect. With cerebral hemorrhage, it's known that it's going to evolve in a pretty expected fashion. As it goes through the acute and subacute phases, there's mnemonics for that. Be itty bitty baby duty for its signal on T1 and T2 at time. But the important thing is noting that it's going to change between bright and dark stages in the acute and subacute phases before it ends up in a T2 dark chronic stage of hemosiderin. And it is the T2 dark stages alone, only those stages that are going to show up on the blood sensitive sequences as being dark, also on the DWI, same way, and have a paramagnetic blooming effect. Whereas the T2 bright stages of blood, these are the ones that won't be dark on the SWI or the DWI, but they are fair game to diffusion restrict on the DWI. So looking at a case of this, we've got a CT head, we've got some ill-defined hypodensity or isodensity in left frontal lobe, very non-specific, but on MR, well-defined T1 bright, T2 bright lesion. On the SWI, it's bright because it's a T2 based sequence, so this is clearly a late subacute hematoma. It's a classic appearance, but showing that it's going to be bright on the SWI, it's only this hemosiderin rim that's dark. And then it is diffusion restricting because the rule for diffusion restriction, if someone says, what is that? What are the rules required to create that appearance? It's anything that's T2 bright and protons don't move in. It's not a genetic test for ischemic infarcts, pyogenic abscess, epidermoid cyst, anything that's T2 bright, protons don't move in. Subacute blood in the T2 bright stage is one of those. So it's nice and diffusion restricting. So if we look at this on our little plotogram, up on top, this is what we just looked at, this subacute hematoma with its bright blood sensitive sequence appearance, B0, it's T2, it's T2 bright. It doesn't lose signal, so it's diffusion restricting. It's the same as an acute infarct for the same reasons. It's T2 bright and the protons don't move. Down here, we've got a case of a patient with a large right MCA territory infarct, but they had petechial hemorrhage in the basal ganglia element. So on the SWI, we can see our T2 dark petechial hemorrhage. Very typical. The B0, it's T2 base. It's got a gradient, so it's also going to be dark there, of course. On the B1000, we can see our acute infarct element, but the basal ganglia is also very dark again, because again, we're getting that same T2 dark blood product, paramagnetic effect, and then everything's dark on the ADC. So again, things that are dark are going to stay dark, and this is very important to note when you're looking at infarcts that commonly have petechial hemorrhage. If they've got T2 dark petechial hemorrhage, it's going to obscure the infarct. And so keep that in mind when we're reading infarcts. So in summary, diffusion weighted imaging, acute, early subacute infarcts, those are the ones that are going to be diffusion restricting. The range on that is minutes to days, but it's a big range, and there's a lot of variability within that from patient to patient. One other caveat that this is really for focal ischemic infarcts, the hypoxic ischemic global anoxic injuries typically will maximize at 3 to 5 days and can have very delayed appearances, often very baffling to a lot of clinicians, and sometimes they don't even ever show up. Subacute infarcts, this is the T2 shine through appearance that might take a couple weeks, lasts up to a couple months, and then chronic is going to be over a couple months. Again, lots of variability from infarct to infarct and patient to patient here, but those are generalities. And then for hemorrhage, it is only the T2 dark stages of blood. seen in various stages of acute, subacute, and then always in the chronic stage, that are going to be dark on the blood sensitive sequences as well as the DWI, and have the paramagnetic blooming effect and can obscure ischemic infarcts when present. And the T2 bright stages of blood are going to be fair game to diffusion restrict. And that's kind of the rule. Anything that's T2 bright, protons don't move in, can diffusion restrict, whether it's this, acute infarct, subacute blood, or T2 bright stages of blood, epidermoid abscess, etc. And that's all I have for this talk. Are there any questions? No?
Is there a way to get the speaker notes off so I can see the screen down here? Could you adjust that really quick? Perfect. All right, so I'm going to talk on craniofacial trauma. I have no disclosures. So I kind of like this topic because facial trauma is pretty ubiquitous. It's essentially everywhere and applicable to nearly everybody, no matter whether you're out in the middle of rural America doing a call shift or at a busy level 1 trauma center. You will certainly see this stuff if you do any sort of neuroradiology on those shifts. It's always important to keep in mind that in neuroradiology, symmetry is our friend. So that can be really helpful. A lot of times these are unilateral injuries, and then you have a normal contralateral side for comparison that can be helpful for trying to decide if a non-displaced lucency is a fracture or a fracture mimic like a suture. Imaging is always performed after the primary trauma survey. Always important to keep that in mind. Airway, breathing, and circulation, the things that are immediate threat to life, need to be addressed first. So CT here is really going to be the gold standard. You just get a better delineation of osseous and soft tissue injuries. And a lot of our surgeons like the ability for 3D reformats. And then lastly, facial radiographs are just kind of becoming obsolete. We have a site in our health system that doesn't have CT capability. It's an urgent care center, and they order a lot of facial radiographs. And I think in those situations, it's just important to protect yourself, and don't be shy about recommending a CT maxillofacial for further evaluation. And really, the ACR appropriateness criteria would support you in that recommendation. So this is the imaging of facial trauma following primary trauma survey, and it might be hard to see here, but they give 4 different variants. And the first one is if you're suspecting a frontal bone injury. So this is green, so this is labeled as usually appropriate. A CT head and a CT max face is going to be recommended in that situation. The second variant they give is if you're suspecting a mid-face injury. The only thing that's labeled as usually appropriate here is a CT maxillofacial. The third variant they give is if you're suspecting a nasal bone injury. So a CT max face would be labeled as usually appropriate. They have ultrasound of the maxillofacial labeled as may be appropriate, but that obviously has its inherent limitations with the inability to penetrate osseous structures with ultrasound sound beam. And then radiography, you can have a lot of overlapping soft tissues or structures in the face. You can miss non-displaced fractures relatively easily. And then lastly, the fourth variant that they give is if you're suspecting a mandibular injury. The only thing recommended here is a CT maxillofacial, or it's labeled as usually appropriate. Again, radiography, even if you see a fracture on facial radiographs, you'll probably be getting a CT maxillofacial anyway, because a lot of times the mandible breaks in 2 spots because it kind of forms a bony ring with a scroll base. So really what you need to be successful in this area is just knowledge of normal facial anatomy and fracture patterns that occur in the face. But it can be really challenging because we're dealing with some of the most complex bony real estate in the human body. And I think this graphic just does a really good job of conveying how complex this region is. So 7 bones comprise the orbit in total, and 4 bones alone comprise the medial orbital wall. So the blue bone is going to be your lamina papyracea, which is a Latin term for paper thin. So this is the portion that fractures a lot with medial orbital blowout fractures. It's a portion of the ethmoid bone. And then you have your lacrimal bone here in red, your orbital surface of your maxilla, and then your lesser wing of the sphenoid also contributes to the medial orbital wall. And typically it's just more useful to describe these things based off their location. So we would just say there's a medial orbital wall blowout fracture rather than try to parse out all the different bones that are involved here. So this is kind of a really important concept to be aware of. We're not going to have a lot of time to talk about it in detail, but it's this concept of facial buttresses and vertical and horizontal buttresses. And so these are really the critical struts for facial form and function. And if any of these things are injured, they're likely to require surgical reconstruction. So you have 4 horizontal buttresses, your upper transverse maxillary, lower transverse maxillary, upper transverse mandibular, and lower transverse mandibular. And then you also have 4 vertical buttresses, which you can see listed here. And these are all kind of color coordinated on this left graphic. So you can see yellow here would be your upper transverse maxillary, green would be your lower transverse maxillary, orange would be your upper transverse mandibular, and purple would be your lower transverse mandibular. And then you just have a whole host of injuries that are associated with fractures along these facial buttresses or struts. And we're not going to have the time to really get into a lot of these things, but a lot of these things require surgical correction. So we'll just look at a few examples. So facial fracture classification, we'll look at a single strut fracture and blowout fracture of the orbit and talk about some complications. So orbital blowout fracture mechanism is going to be a direct blow to the central orbit or fist by a fist or a ball typically. And you basically just get decompression at the weakest points of the orbit. And the majority of the time that's going to be your orbital floor, which you can see here. And then the second most common will be your medial orbital wall. They can occur together as well. So the presentation and diagnosis can be delayed. These patients can have significant swelling and they can have an intact orbital rim, which can make it challenging for clinicians to diagnose this clinically. Clinical symptoms are kind of what you would suspect. So anytime you have an orbital blowout fracture, you technically increase the orbital volume. So your globe will shrink back a little bit in your orbit. Diplopia, if you have extraocular muscle entrapment, you can have quite a bit of gas in the orbit with these because there's communication with the adjacent paranasal sinus. And then malar region numbness. So this graphic is showing injury to the left infraorbital frame. And so you would expect a left V2 distribution of numbness and tingling. And then hypoglobus just means inferior displacement of the globe. So here's just a case showing the classic right inferior orbital blowout fracture. You have herniation of extraconal orbital fat into the superior aspect of the maxillary sinus. And then the inferior rectus muscle is kind of vertically oriented and extending into the fracture defect. You need to probably get on the phone with a clinician on this one and see what their concern is for inferior rectus entrapment. Really important variant that occurs with the orbital blowout fracture is this trapdoor fracture. Typically occurs in young children and adults, mainly affects the inferior orbital wall, but it can happen in the medial wall as well. And the physiology here is that children's bones are just more elastic than adult bone. They have more cancellous bone relative to cortical bone. And what happens is that you have a fractured bone flap, it returns to its original position. And when it does that, it's at high risk for entrapment. And a lot of times these are termed wide-eyed blowout fracture because they can be really challenging clinically to diagnose because they can have a lack of external clinical signs. These patients sometimes do not have a lot of periorbital bruising or subconjunctival hemorrhage. So here's a case of a trapdoor fracture. So you can see here's the bone flap, that inferior orbital blowout fracture. So at one point that extended inferiorly, and when it returned into its original position, it trapped the waist of the inferior rectus muscle. And a lot of people say that this resembles an hourglass morphology, which I think fits pretty well. So anytime we talk about injuries or facial fractures, we have to talk about globe injuries. And so this is a real significant cause of disability, especially in the young men demographic, because a lot of the causes kind of center around that age group: motor vehicle accidents, sports-related accidents, industrial accidents, falls, violent trauma. So here's an industrial-related accident, tiny piece of iron lodged at the margin of the cornea. So really what these patients need is an urgent clinical ophthalmologic evaluation. However, if you think about this patient population, the radiologist really plays a key role in the care because a lot of the physical exams from ophthalmology for these patients are really limited, whether it be due to significant swelling, other craniofacial injuries, unresponsiveness, altered mentation, or sedation. And so this is actually a radiograph from 1909 I found online that so we've been using radiography for over 115 years to diagnose orbital foreign bodies. Just show some complications here of globe injuries. So this is kind of classic globe rupture case due to blunt injury. Just have loss of normal definition and architecture of that right globe, the anterior posterior segment differentiation, ill-defined density filling the globe, edema at the extraocular muscle insertion sites, and periorbital edema. It's a case I had a couple weeks ago on call. This is globe rupture due to penetrating trauma. So you can see the normal globe here on the right, and then you just have ill-defined hyperdense tissue where the globe used to be, and then just ballistic fragments in that area as well. Retrobulbar hemorrhage. So here you have postseptal, extraconal, superior retrobulbar hemorrhages, and this would probably be another phone call to the clinician. This patient would be at risk for orbital compartment syndrome. Obviously, they got a lot of other things going on intracranially as well. Lens dislocation. So you can see just the lens layering along the posterior segment of the globe on an axial non-contrast CT, as well as an axial T2 weighted MR. And just to remind folks, you can actually have an anterior lens dislocation. So this lens is dislocated anteriorly relative to the opposite side. Retinal detachment, we see this from time to time. So you have intraocular hyperdense leaflets along the medial and the lateral portions of the globe. The important thing here is that it comes to an apex or kind of terminates right at that optic disc region. This is a flare image, so these are going to be flare bright collections. So this is going to be blood. This would be most suggestive of a retinal detachment. In contradistinction to this, which is a choroidal detachment, now you have intraocular hyperdense leaflets, but as in a prior case, it does not converge or come to an apex on that optic disc region. This would be more suggestive of a choroidal detachment. And then just a case of vitreous hemorrhage, you can see relatively homogeneous density filling that posterior segment or vitreous body of the globe with periorbital edema as well. All right, so now we'll look at some lateral midface injuries. So let's start with the zygomaticromaxillary complex fractures. So ZMC fracture, these have a bunch of different names. You will definitely see these in practice. They're the second most common midface fracture after a nasal bone. So what's all involved in a ZMC fracture? So your frontozygomatic suture will be your lateral orbital rim involvement. Your temporozygomatic suture will be your zygomatic arch involvement. And then your zygomaticromaxillary suture will be your inferior orbital rim and your anterior and posterior lateral maxillary sinus wall involvement. Another case I had a couple weeks ago on call. So beautiful 3D rendering showing a ZMC fracture. So here's your zygomatic arch involvement, lateral orbital rim, inferior orbital wall, and then your maxillary sinus wall involvement here. Another case from the literature on the opposite sides showing a ZMC fracture. This case has just increased separation or disarticulation of the left malar eminence. So this one is lateral frontal diagonal transsphenoidal basilar skull fracture. This is it's a mouthful, and it's a different beast. So this is a much more serious basilar skull fracture. It's usually associated with traumatic brain injury, crosses midline, and it can involve pterygoid plate. So the reason I included it here was because the direction of impact is very similar to a ZMC. It's anterolateral. But if you look at this location and their direction of impact, this can cause a bunch of issues. So it goes through the orbital roof, through the orbital apex. So your optic nerve would be at injury. You're at risk for orbital apex syndrome. And then it crosses at the posterior wall of the sphenoid sinus, and then comes in close proximity to the carotid canal, which is here. So you'd be at risk for an ICA injury, cavernous carotid fistula, and then it exits along the contralateral tympanic or petrous portion of the temporal bone. So here you'd be at risk for a CSF leak or venous thrombosis. This is basically the same thing, just showing the fracture pattern from the literature and just from the opposite side. So we'll go through some of the complications here. So with this fracture pattern, you're at risk for orbital apex syndrome. So Here's your normal optic strut, anterior clinoid process, optic canal, superior orbital fissure, foramen rotundum, and Vidian canal. And on the opposite side, you can see that there's tiny fracture fragments and a couple foci of gas associated with that right optic canal. And there's a fracture here associated with the right superior orbital fissure. So this patient would have superior orbital fissure or orbital apex syndrome. This is an axial CTA MIP slab through the brain. So with this fracture pattern, you're also at risk for cavernous carotid fistula. So remember, this is an arterially timed study, and you are seeing venous engorgement and dilation here. So your superior ophthalmic veins bilaterally and your cavernous sinus are both dilated. So you should suggest that there may be an underlying cavernous carotid fistula, and cerebral angiography would be your next recommendation. Carotid canal injury. So here's a left carotid canal injury, decreased caliber, irregularity, opacification of left carotid canal. At our institution, we use the Biffle scale for blunt cerebrovascular injury. So grade 1 would be the most mild with less than 25% luminal narrowing, all the way up to grade 5, which is the most severe transection with free extravasation. So unfortunately, a lot of those patients probably don't make it to the hospital. And then just to remind people that this does exit the contralateral temporal bone. So anytime you cross a sinus with a fracture, you're at risk for venous thrombosis. So that's what you're seeing here. This is left sigmoid sinus venous thrombosis. And then a subset or a minority of those patients will go on and develop a hemorrhagic venous infarct. All right, so we'll talk about central midface injuries quickly here. So these are going to be your classic smash face injuries. They're named after the bones that are involved, typically high impact injuries. So nasofrontoethmoid impact region is going to be right here. Nasoorbital is going to be in this region. So a bunch of associated injuries with these, but the main ones are going to be nasolacrimal duct damage, CSF leak, orbital injuries. And then the real big one with the nasoorbital is going to be this telecanthus, which basically just means increased widening between the inner corners of the eyelid due to medial canthal tendon injury. So here's a case of just classic central midface nasoorbital smash fracture pattern. And if if you had involvement in the frontal bone or the frontal sinuses, you would just include NFE. So all these things over here are fractured in this case. So this is kind of what I was alluding to previously. For nasoorbital fractures, there's this Markowitz and Manson classification system, and this is based on the integrity of the medial canthal ligament. So the medial canthal ligament is this structure right here. It inserts on the medial orbital wall, kind of at the level of the lacrimal fossa. And we can't see this ligament by CT, but you can describe the degree of comminution at this medial orbital wall, and it'd be helpful for surgical planning. So this is the different stages of injury to this. So your type 1 injury is going to be your medial canthal tendon is intact. So this is your medial canthal tendon, and it's attached to a dominant fracture fragment. Your type 2 injury is going to be your fracture is comminuted. So you have comminuted fractures down here, but the tendon is still attached to a dominant fracture fragment. And then lastly, type 3 is going to be you have comminuted fragments extending to where the tendon inserts on the medial orbital wall, which you see that here. And then you also have resultant avulsion of the tendon. So this is going to be the most difficult to deal with clinically, and this needs to be surgically corrected. And just kind of threw this in just to remind people what a nasolacrimal duct fracture looks like. So number one cause of a traumatic nasolacrimal injury is going to be a nasoorbital pattern of fracture. All right, so now we'll just briefly touch on transfacial injuries, Lefort fracture pattern classification. So by definition, Lefort injuries must involve the pterygoid plates. You get some real unique clinical symptoms with this. You can have a mobile maxillary alveolus, midface, or your entire face can separate from your skull base. They can be unilateral or asymmetric. They can occur with other, any of these things can occur with other fracture patterns, ZMC or nasoorbital. But your Lefort 1 pattern is going to be a horizontal maxillary fracture separating the teeth from the upper face. This will give you the classic floating palate. So it's a transverse fracture through the maxillary sinus walls, and most importantly, the thing that's kind of going to define a Lefort 1 is that it has medial maxillary sinus wall involvement. So the red is going to be your Lefort 1 injury. So here you can see that there's pterygoid plate fractures, which we need for our Lefort classification. And then you have fractures of the anterior and the posterior lateral maxillary sinus walls, as well as the medial sinus walls, which you see right here. So that medial wall involvement is going to define your Lefort 1. So red is going to be your Lefort 1 on the 3D rendering. Fort 2 is going to be a pyramid-shaped fracture with teeth at the pyramid base and the nasofrontal suture at the apex. It's a oblique fracture involving the orbital wall. And this is the thing that's going to define in Lefort 2 is the orbital floor or the orbital rim involvement. You also have fractures of the maxillary sinus walls and the pterygoid plates. So Lefort 2 is going to be blue here. Here's your maxillary sinus wall involvement. And then the thing that's going to define in Lefort 2 is the orbital floor or inferior orbital rim involvement. Blue is going to be your Lefort 2 on the 3D rendering. And then lastly, Lefort 3, transverse fracture involving the nasal bone, medial and lateral orbital walls, zygomatic arch. So the lateral orbital wall involvement and the zygomatic arch involvement will define your Lefort 3. And this one, you get craniofacial disassociation. So your face essentially separates from your scroll base. So yellow is going to be a Lefort 3. Here's your zygomatic arch involvement, lateral orbital rim involvement, medial orbital wall involvement. And here's a nice diagram just kind of summarizing everything we just talked about. This is from Tabby Kennedy at the University of Wisconsin. So you need pterygoid plate involvement for all these. And then the thing that's going to define a Lefort 1 is the medial maxillary sinus wall. Lefort 2 is going to be orbital floor, orbital rim. And a Lefort 3 is going to be your lateral orbital wall and your zygomatic arch. So that's everything we kind of talked about here. Single strut, lateral midface, central midface, transfacial fractures. So list of references. And thank you.
Okay, so it started. I have no pertinent disclosures. I'm open to them though, but there's no reps in the room, so yeah. Just a big thank you to my former colleagues who allowed me to use some of their graphics in my presentation today. So we'll be doing a brief overview of head and neck anatomy, recognize the role of imaging in the evaluation of acute head and neck pathology, and review important imaging features of non-traumatic head and neck pathology typically seen in the ER. So this is by no means all-inclusive, but I do think it's important to review the deep cervical fascial planes. These are important barriers to the spread of infection in the neck. And when a disease is established, they provide specific routes of spread for pathology, and they also create the deep neck spaces. So we have the 3 layers of the deep cervical fascia. We have this superficial layer, which is the investing layer. It encases the neck deep to the platysma muscle and encases the sternocleidomastoid and trapezius muscle, also splits to form the capsules for the masticator, parotid, and submandibular spaces. It's designated in yellow in the graphic. And then we have the middle layer of the deep cervical fascia, which encases the pharyngeal mucosal space in the suprahyoid neck and the visceral space in the infrahyoid neck. It's designated in magenta on the drawing. And then we have the deep layer of the deep cervical fascia, which encases the paraspinous muscles and forms the perivertebral space. So again, the deep cervical fascial planes create the deep neck spaces. We typically talk about it between the suprahyoid and infrahyoid neck because the anatomy of the deep cervical fascia is a little bit different and below the hyoid. So first we have the parapharyngeal space. So it's mainly filled with fat. Okay. And really the purpose of the main benefit of the parapharyngeal space is we can use the fat displacement pattern to localize the lesion. That one there. Next, we have the pharyngeal mucosal space, which is again encased by that middle layer of the deep cervical fascia. It contains the mucosa, lymphatic ring, minor salivary glands. And its importance is its proximity to the retropharyngeal space and then the danger space. We have the masticator space, which is again encased by the superficial layer of the deep cervical fascia. It extends from the suprazygomatic fossa to the inferior mandible, contains the V3 segment, muscles of mastication, and a majority of the mandible. We have the parotid space, again encased by that superficial layer of the deep cervical fascia, containing the deep and superficial parotid lobes and cranial nerve 7. The carotid space is encased by all 3 layers of the deep cervical fascia. The difference is in the suprahyoid neck, it has deficient margins, so it's not a complete sheath. It's more intact in the infrahyoid neck. The carotid space contains cranial nerves 9 through 12, the carotid artery, and internal jugular vein. Then we have the submandibular space, also encased by that superficial layer of the deep cervical fascia. It contains a submandibular gland and level 1 lymph nodes. We talk about it in relation to the sublingual space, which are separated by that mylohyoid muscular ring. The sublingual space is superior and medial to the submandibular space. These 2 spaces connect posteriorly along the posterior margin of the mylohyoid muscle. It's important to highlight the areas where those deep neck spaces abut the skull base, as these are potential intracranial routes of spread for disease. The pharyngeal mucosal space abuts the skull base at the basisphenoid and basioccipital region. There are triangular shaped openings in the bone that aren't true foramen, but are called foramen lacerum, predominantly filled with cartilage, but could have access intracranially. We have the masticator space, which abuts the skull base at that high-heeled footprint, so the foramen ovale and foramen spinosum, which transmit V3 and the middle meningeal artery, respectively. The parotid space abuts the skull base at the stylomastoid foramen, which transmits the facial nerve. And then the carotid space abuts the skull base at the level of the jugular foramen and hypoglossal canal, associated with cranial nerves 9 through 12. The posterior midline spaces, so posterior to the pharyngeal mucosal space, and between that middle layer of the deep cervical fascia and the alar fascia, we have the retropharyngeal space. It extends to about the thoracocervical junction, where the buccopharyngeal fascia, which is a component of that middle layer, joins the alar fascia. Posterior to that, we have the danger space, which is between that alar fascia and the prevertebral fascia. And it's important because it extends from the skull base to the mediastinum, allowing for disease to spread to the chest from the neck. This is just a graphic showing a patient with deep neck emphysema, the difference between the retropharyngeal space and the danger space on that thin slip of alar fascia. And then we have the perivertebral space, again encased with that deep layer of the deep cervical fascia. It attaches sends a slip to the transverse processes, and that kind of defines a space into anterior and posterior components, anteriorly being the prevertebral space, which is between that alar fascia, the prevertebral fascia and the spine, and then posteriorly the paraspinous space. Infrahyoid neck, I'm just going to highlight the ones we haven't really talked about because many of the spaces are contiguous. So the posterior cervical space mainly contains fat and lymph nodes. It's between the superficial and deep layers of the deep cervical fascia. And while like the bulk of this space is in the infrahyoid neck, it does extend into the suprahyoid neck as well. It's just a CT showing that same space. Then the visceral space, which is contiguous with the pharyngeal mucosal space, and again encased with that middle layer of the deep cervical fascia, containing the larynx, hypopharynx, cervical trachea, esophagus, and the tracheoesophageal groove structures, thyroid, parathyroid. All right, let's get to some cases. So we have a 90-year-old female presenting with sinus pressure and fever, coronal CT demonstrating a pacification of the visualized ethmoid sinuses and maxillary sinuses. Axial CT through the level of the frontal sinus, which is predominantly opacified with an area of cortical breakthrough through the outer calvarial table where there is an associated rim enhancing abscess. So this is the case of osteomeatal unit complicated sinusitis with subperiosteal abscess. We call that the Potts-Puffy tumor, which is that subgaleal or subperiosteal abscess associated with osteomyelitis secondary to frontal sinusitis. It's important to highlight the intracranial spread of infections such as epidural abscess, subdural empyema, brain abscess, cerebritis, dural or other cortical vein thrombosis. We're going to recommend MRI to best evaluate for that intracranial spread of infection. Treatment's going to, of course, be surgical decompression of the abscess and IV antibiotics. Next, we have a patient presenting with left facial swelling. They're immune compromised with a history of myelofibrosis and prior stem cell transplant. So we have axial CT through the maxillary sinus, which is near completely opacified. We see a subtle area of bony thinning and irregularity along that posterior maxillary wall, and then just significant surrounding soft tissue inflammatory change. Follow-up MRI in the same patient, we see an area of non-enhancing mucosa in that affected left maxillary sinus, and then just extensive extrasinus extension of infection, including the premaxillary and retroantral masticator space, as well as the orbit. So this is a case of invasive fungal sinusitis. It's a rapidly progressing infection from the sinuses by vascular invasion, most commonly in an immune-compromised patient or poorly controlled diabetes. And the most common culprits are going to be Aspergillus and mucor. Patients will present with fever, facial pain, decreased malar sensation. Again, CT findings are going to be that sinus opacification with bone erosion. That's really important. The degree of really mucosal thickening might be very mild, where we're looking for adjacent soft tissue infiltration. It's really soft tissue where there shouldn't be in that fat surrounding the sinuses. MRI is going to be our best way to evaluate for that non-enhancing mucosa and interorbital and intracranial extension. Treatment's going to be radical surgical debridement, so it's really important for us to tell our surgical colleagues where the infection is spread to, and then, of course, antifungal treatment. 16-year-old male presenting with epistaxis. So we have a hyper-enhancing mass centered within the posterior nasal cavity and nasopharynx. There's associated widening and expansion of the sphenopalatine foramen and extension into the pterygopalatine fossa. So this is a case of juvenile nasopharyngeal angiofibroma. This is a highly vascular tumor, again, arising from that sphenopalatine foramen and may extend laterally into the pterygopalatine fossa as well as the nasal cavity and and nasopharynx. It's almost exclusively seen in young males. Treatment's going to be preoperative endovascular embolization. This is our patient, the pre-treatment ECA injection, followed by particle embolization. You can see significantly decreased vascularity of that tumor, then followed by surgical resection. 55-year-old female presenting with left eye swelling. So we have abnormal posterior ocular tenting, stretching of the optic nerve surrounding periorbital inflammation. Follow-up MRI, we see again that periorbital and intraorbital inflammation in the intraconal and extraconal spaces, as well as again that abnormal conical contour of the posterior globe. So this is a case of orbital compartment syndrome. It is an emergent finding that could lead to permanent visual impairment if untreated due to the increased intraorbital pressure and optic nerve ischemia. It can be seen in the post-traumatic setting, as Dr. Werth mentioned. In our case, it was a case of idiopathic orbital inflammation post-biopsy. So again, the patient's imaging findings will be proptosis. We're going to see tenting of the globe or the guitar pick sign, so that abnormal conical contour of the posterior globe and stretching of the optic nerve. Treatment, of course, is going to be urgent decompression with lateral canthotomy. We have a patient with left-sided neck swelling and pain. The level of the submandibular space, we have a rim-enhancing collection, which extends superiorly into the sublingual space and floor of the mouth region, with just really extensive surrounding fat stranding. So this is a case of Ludwig's angina. It's a rapidly progressive infection of the floor of mouth involving the sublingual, submandibular, and submental spaces. Really, the importance here is the infection displacing that posterior tongue, resulting in rapid airway compromise. It's commonly due to dental infection. Treatment is mainly going to be that airway protection and any drainable collection should be urgently surgically decompressed. Next, we have a 21-year-old male presenting with throat pain. So we see asymmetric enlargement and enhancement of that right palatine tonsil with a collection along the anterolateral margin of the tonsil. This is a case of tonsillitis with peritonsillar abscess. So the imaging findings of tonsillitis are going to be enlarged tonsil with strident enhancements. We see that nice strident enhancement in this image. And the peritonsillar abscess is going to be that rim enhancing collection. The peritonsillar component is that it's between the tonsillar capsule and the superior pharyngeal constrictor muscle. This is just an image showing that superior pharyngeal constrictor muscle going from the pterygomandibular raphe posterior along the pharyngeal mucosal space. So the peritonsillar space is going to be between that tonsillar capsule and the superior pharyngeal constrictor muscle, which obviously can be very difficult to evaluate by imaging. There's a lot of debate about whether things are intertonsillar or peritonsillar. I think our job is more to determine if a finding is present. Is it an abscess or phlegmon? A phlegmon is going to be more ill-defined, won't have a higher Hounsfield unit, and without that nice well-defined wall that we see in an abscess. It's going to be important for us to evaluate for an extended abscess spreading into the adjacent spaces. Those patients will obviously, the surgical decompression will be more extensive, and then to evaluate for any surgical relevant anatomy such as retropharyngeal course of the ICA. A 41-year-old female, after intentional ingestion, she has a rounded radiopaque foreign body at the level of her trachea. The important features of this foreign body are that it has a beveled edge. And if we look at the image with it on FOSS, we see kind of a double ring appearance, or a ring inside of a ring. So this is a button battery ingestion. So it's important to differentiate the button battery from a coin. The battery is going to need immediate removal due to potentially catastrophic mucosal injury. Again, we're looking for that beveled edge appearance and then the double ring or the ring in the ring. 61-year-old male with a history of laryngeal cancer, and he has now drainage from his neck wound. So we see this large necrotic laryngeal mass, at least partially encasing the left carotid artery. Comparing to the exam from 2 months prior, we see that there is new luminal irregularity and focal outpouching of that left carotid artery at the level of the necrotic mass. The CTA MIP image confirms that area of pseudoaneurysm, and then also on the diagnostic angiogram. So this is impending carotid blowout syndrome. So this is most commonly in patients with treated head and neck cancer. Risk is going to increase with anything that it causes vessel wall injury, radiation, necrosis, infection, tumor. Of course, has a high risk of mortality and neurological morbidity. CTA is going to be the modality of choice to evaluate because we can see the surrounding structures and the vessel. Active extravasation, pseudoaneurysm, and exposed vessel are the most important imaging features and the main indicators for aggressive treatment. Treatment's going to be predominantly endovascular with embolization or stent placement. Stent just have a high rate of complications. So this is our patient treated with carotid takedown. 66-year-old female presenting with neck pain. So we have sagittal CT images, soft tissue and bone window with a comparison. We have abnormal prevertebral edema and thickening and a new amorphous calcification at the C1, C2 level. We just see axial sequences to that same level, again demonstrating the prevertebral edema and the amorphous calcification. So this is an example of acute calcific longus coli tendinitis. It's an inflammatory response to calcium hydroxyapatite crystal deposition in the longus coli tendon. Again, we're going to see that amorphous calcification within the prevertebral tissues at C1, C2. Sometimes we'll have retropharyngeal effusion. It's important to differentiate that from abscess. There will not be rim enhancement. This is a self-limiting condition. It's treated with pain meds and NSAIDs. 71-year-old male presenting with neck pain. So we have a sagittal CT through the C-spine with irregular erosive bony erosion of the lower vertebral bodies. and then ill-defined prevertebral edema and inflammation. Follow-up MRI, so we have vertebral body collapse and kyphotic or gibbous deformity. We have confluent T1 hypointense enhancing marrow signal with subligamentous extension of the phlegmon and extension into the epidural space posteriorly as well. Axial just confirming those findings with all the inflammation in the perivertebral space. This was an example of tuberculosis, spondylodiscitis. Features are going to be end plate destruction and vertebral collapse with gibbous deformity. TB typically spares the disc space due to the sparse vascularity, in contrast to pyogenic osteo, which the disc spaces are typically involved. Again, there's going to be that subligamentous spread. Our checkpoints are going to be what is it doing to the cord? Is there cord compression and cord edema? And then, of course, surgical decompression and anti-TB meds will be used for treatment. So remember those anatomic checkpoints and fascial planes. They create barriers to disease and routes of spread and create the deep neck spaces. CT is really going to be the workhorse of imaging in the emergent setting of the head and neck. MRI can be used to supplement. And then important features of acute and fungal sinusitis of the bone erosion and soft tissue invasion. Orbital compartment syndrome is a vision and threatening emergency. Look for that guitar pick appearance or globe tenting. And then the main features of carotid blowout syndrome, vessel exposure, pseudoaneurysm, and arterial extravasation. Okay, that's it. Thank you.